السلام عليكم ورحمة الله وبركاته. أنا عمر ليث من سنة ثانية كلية الطب، واليوم راح أتكلم عن الكارديوفاسكولار هيستوري تيكينج، تحديدا chief complaints with associated symptoms مال every differential. I would like to begin this video by giving credits to Dr. Mada Daghistani. She created this file that has lots of info regarding the bases and the how we take history in cardiovascular patients, and it is very informative. I'll put the link in the description. طبعا when it comes to diagnosis, you all gonna become doctors, and including me inshallah. It's like a Sudoku game. You are provided with numbers. You have to guess the other numbers in order to complete the puzzle. Well, the thing about medicine is that the patient does not enter your clinic with the diagnosis written on them. Like, you do not know if this patient has cardiovascular or respiratory or GI. So you have to listen carefully to the patient and make connections in your mind. طبعا بالنسبة most common cardiovascular complaints are 4: chest pain, shortness of breath plus cough, palpitations, and syncope. If a patient comes to your clinic complaining of one or more of these symptoms, you have to put in mind that he might have a cardiovascular issue. Not only cardiovascular, it can be respiratory, it can be GI, but cardiovascular is on the table. نجي هسه على واحدة من هذول complaints. If the patient come to you complaining of chest pain, طبعا بالنسبة للchest pain, it has two main causes, either cardiac causes or non-cardiac causes. Talking about the cardiac causes, it can arise from the heart or the aorta. If it's from the heart, it is either angina or myocardial infarction or pericarditis. If it's from the aorta, it can be dissecting aorta, aortic aneurysm. The cause can be non-cardiac. For example, respiratory. You have pneumonia. You have pulmonary embolism, which we will take more in the respiratory unit. It can be due to GIT, like GERD. It can be due to trauma, like a broken rib, etc. طبعا بالنسبة للchest pain, the normal sequence of questions is we're going to follow Wakabi. When, where, quality, quantity, alleviating, aggravating factors, and associated symptoms, and finally the beliefs. We're going to come to the first diagnosis, which is angina. Now, how do people with angina present to the clinic? First of all, we start with the when. And when it has 3 parts: onset, duration, and progression. When it comes to the onset, it has an acute onset. It occurs suddenly. And for the duration, it is episodic. It comes and goes, and it's very important when something is episodic to ask how much time does it last for. For angina, the chest pain lasts for less than 20 minutes. And it's also important to ask what turns on the pain, since it's episodic. If the patient says on exertion, you have to put in mind that it might be stable angina. If it's unpredictable, arises by doing nothing, like for example resting, you have to put in mind that this patient has unstable angina. Next, the progression is variable. Some people, it becomes better. Some people, it becomes worse, because there are many factors determining this. Maybe they have stress, so you have to put this in mind. Next, we have the location. The chest pain is mostly retrosternal, behind the sternum, and radiation is unlikely when it comes to angina. Next, we have the quality of the pain. We ask What does the pain feel like? It's a heavy pressure squeezing pain. Pressure pain to the point that it feels like a rock is placed on the chest. Squeezing pain, imagine if you have like a rope wrapped around your chest and someone is squeezing. This is the idea. Or the patient might say this. Next, we have the alleviating factors. If the patient says إنه rest or nitroglycerin improves his condition, then you have to put in mind that it might be stable angina. If nothing makes it better, it's unstable angina. Regarding the aggravating factors, exertion makes the pain worse in both stable and unstable. So they might say by walking, by running, by climbing the stairs, by doing the housework. Next, we have the associated symptoms. Angina associated symptom is usually shortness of breath or dyspnea. This is because during the attacks there is chest pain, and this chest pain may prevent the patient from breathing normally. Next, we have the myocardial infarction, which is very dangerous. Again, starting with when. The onset, it's an acute onset. The duration, it's a continuous pain. More than 20 minutes. And the progression, it becomes worse. So this is one of the points that you can differentiate between angina and myocardial infarction is that it lasts more than 20 minutes. Less than 20 minutes, angina. Regarding the location, it's a retrosternal pain behind the sternum and can radiate to the left chest, shoulder, arm, neck, and jaw. This is specific. The quality of the pain, it's usually heavy pressure squeezing pain. Alleviating factors, nothing makes it better because the heart muscle is dying. The aggravating factor is exertion in any time. The quantity of the pain, it's much higher than angina. They might say 9 or 8. It's a very sharp pain. Associated symptoms of myocardial infarction, we have sweating due to activation of the sympathetic nervous system, dyspnea because of the pain, palpitations, and vomiting sometimes. You have to put these in mind. Next, we have pericarditis. Pericarditis is inflammation of the pericardium. Regarding the when, onset, it's an acute onset. Duration, pain is continuous because there is friction as the heart beats. There is friction in the serous pericardium, and the progression is usually constant. It doesn't get worse, it doesn't get better. Regarding the location, it's retrosternal, behind the sternum, and can radiate either to the left or both shoulders. Quality of the pain, it's a sharp stabbing pain. It's an acute pain. Alleviating factors, sitting up and leaning forward because this maneuver reduces the friction. فالpain decreases. And over-the-counter painkillers like, for example, Panadol, etc. Aggravating factors is the opposite, lying flat, because it decreases the space in the pericardium and increases the friction. Deep breaths, coughing, anything that causes thoracic movement. And with the associated symptoms, first we have fever. It's an inflammation, itis, fever. 2 is dyspnea. 3, palpitations. Next, we have dissecting aorta. It's a fatal condition and it requires urgent intervention. When? Onset, acute onset. Duration, it's continuous. Progression, it becomes worse. The location of the pain. It's retrosternal, behind the sternum, and the pain can radiate to the back. This is important to know. Quality of the pain, it's a tearing pain. Imagine if you have a fabric and you have a knife and you're cutting that fabric with the knife, the same thing. Alleviating factor, nothing. Aggravating factor, شو تريد بعد? It's an emergency. It's fatal. You have to get him to the operation room. Associated symptoms, syncope and dizziness because of the hypotension. Blood is entering between the layers of the aorta wall. Blood is not going to the brain, so it causes fainting, dizziness. Quantity close to 10. هذا إذا كان conscious. بالنسبة للأورtic aneurysm is similar to dissecting aorta as we mentioned, بس إنه الأنيوريزم it's dilatation of all the vessel wall layers. هذا الأنيوريزم. أما بالنسبة للدissection إنه separation of the layers which allows the blood to enter between them. Both of them are very dangerous. Next we have a pulmonary embolism, which is a respiratory cause. Pulmonary embolism is basically when you have an embolus blocking the blood flow to the lungs, causing lung infarction. So it's similar to myocardial infarction, but it's in the lungs. وشغلة كلش مهمة بالنسبة للpulmonary embolism, it is mainly caused by deep vein thrombosis. Now, this happens in bedridden patients, in lack of activity. And you have to ask number of questions regarding traveling, for example. Like, do you travel a lot? Because when you travel, especially for long periods of times, you sit. And this increases the risk of deep vein thrombosis. This is an important question you can ask the patient. Talking about when. Onset, acute onset. Duration, it's continuous. Progression, it becomes worse because there is necrosis in the lungs, where the location of the pain is generalized around the thorax, around the chest. The quality of the pain, pulmonary embolism produces something called pleurotic chest pain, which is pain while taking a breath. And the alleviating factor, nothing. Aggravating factor, we just said, no, pain increases when you take a breath, so breathing. So the patient tells you, when I take a breath, when I breathe normally, it's very painful. And the associated symptoms, number one, dyspnea. Patient is unable to breathe. Second, we have hemoptysis. Hemoptysis is basically coughing blood in sputum. It can be present, it cannot be present, depends. Why does this happen? Because you have necrosis of the lungs, and this necrosis of the lungs causes bleeding, which might enter the bronchioles, goes up the trachea, and with the coughing maneuver, it can exit with the sputum. Next, we have pneumonia. We will take pneumonia in details in the respiratory unit. When? The onset is subacute onset. الفرق بين الأكيوت والسب-acute إن الأكيوت minutes to hours. أما بالنسبة للسب-acute days to weeks. The duration is continuous. The progression it is variable. Where generalized chest pain all around the chest because it's inflammation of the lungs. Quality of the pain, again, pleuritic or pleuritic chest pain, which is pain while taking a breath. Aggravating factor, breathing. Associated symptoms, we have fever because there is inflammation. So if the patient has a fever, you have to put, and he has chest pain, you have to put in mind pneumonia. 2, dyspnea. 3, productive cough. Coughing with sputum. Now, the second complaint we have is dyspnea. And regarding the causes, we have 2. We have cardiac and non-cardiac causes again. The cardiac can be the ones that we mentioned: angina, myocardial infarction, pericarditis, and the new ones which are the heart failure and valvular diseases. نيجي هسه للheart failure. The heart failure is defined as inability of the heart in pumping the blood into the circulation. And there are three types: either right-sided heart failure, or left-sided heart failure, or both, which is called congestive heart failure. Now, dyspnea occurs when we have left-sided heart failure. Why? لأنه left-sided heart failure is not pumping the blood into the aorta, into the systemic circulation, so it's not receiving the blood from the pulmonary. So this will lead to congestion of the blood in the pulmonary circulation, producing the dyspnea symptom. Now, the dyspnea is non-pain symptom, so we follow OD para. Now, O is for onset. The onset is chronic. It doesn't develop suddenly, it develops gradually and takes a long time, so it's chronic. D, duration, it's continuous. P is progression, it becomes worse over time. Talking about the alleviating factor is basically sitting up. Aggravating factor is the opposite, lying flat. Dyspnea gets worse when you lie flat. This is called orthopnea. And also, dyspnea gets worse on exertion. Associated symptoms. طبعا قبل ما نجي, there are important questions that you have to ask in these conditions if you put the heart failure in your mind when the patient presents with dyspnea. You ask إنه if this shortness of breath wakes him at night. This is called P and D. And if the shortness of breath occurs while lying flat, how many pillows does he use? And we took this in one of the scenarios during OSCE, and any legs swelling, we'll get into that. The associated symptoms, we have general fatigue. Why? لأنه عندنا low cardiac output to all the organs in the body, causing the fatigue. If the dyspnea comes with peripheral edema, pitting edema particularly in the lower limbs, then it is congestive heart failure. So you have left-sided heart failure and right-sided heart failure, both of them. Plus minus productive cough or pink frothy cough. The reason behind this, we have blood engorged in the pulmonary circulation. This might damage the vessels, the small capillaries, which might lead to bleeding in the bronchioles and produce this cough, pink frothy cough. نجي هسه للmitral stenosis, one of the valvular diseases. Talking about the onset, chronic onset again, doesn't develop suddenly, it develops gradually. Duration, it's continuous. And regarding the progression, becomes worse. Alleviating factor, usually nothing. Nothing makes the shortness of breath better. Aggravating factor, lying flat, which is also orthopnea. And exertion, same as heart failure. Associated symptoms, hemoptysis. نفس السبب إنه عندنا pulmonary hypertension that might damage the capillaries and lead to bleeding in the bronchioles, causing coughing blood. Second, we have fatigue. And third, which is special when it comes to mitral stenosis, is voice hoarseness due to left atrial enlargement. Now, when the left atrium enlarges, it might compress a branch of the vagus nerve called the left recurrent laryngeal nerves. Again, we have to ask these questions. Now, the third complaint is syncope, loss of consciousness. Now, this is caused by decreased cerebral perfusion. Blood supply to the cerebrum decreased. الدم بدي يروح للدماغ. It causes cardiac, non-cardiac. We'll focus on the cardiac ones. It can be caused by dissecting aorta, aortic aneurysms, the one that we took, and new ones, aortic stenosis. If you remember the triad, which includes what? Syncope, heart failure, angina from the hospital lecture, and sick sinus syndrome, which is basically a type of arrhythmia or sinus node dysfunction. The fourth and last complaint is palpitations. When it comes to palpitations, there are many causes, including pericarditis, myocardial infarction, but mainly arrhythmias. So if the patient presents to you with palpitations, he says that he can feel his heart pumping or beating, pumping so hard, you have to put these differentials in your mind. Now, next we have two cases that are worth mentioning. A rheumatic fever. Although it is less common nowadays, but we have to know the clinical presentation of it. We are all familiar with Jones criteria. We took this in Dr. Ibrahim Hashim's lecture. Jones criteria, number one, joint involvement. If the patient presents to you complaining of arthritis, joint pain that is migrating to different joints, like for example, it starts in the knees, goes to the hip, goes to the elbow, goes to the ankle, you have to put in mind rheumatic fever. Or carditis, including endocarditis, myocarditis, pericarditis. And subcutaneous nodules. E, erythema, redness of the skin. S, Sydenham chorea. These are the major criteria. Next, we have the infective endocarditis. Now, the symptoms that the patient might complain is, it's an inflammation, so there must be fever. There might be chest pain, palpitations, fatigue, anorexia, weight loss. And the signs that you are going to see in the physical examination are rough spots on the retina of the eye, bilateral crackers, heart murmurs. These two are the most important, fever and heart murmurs. If these two are combined, it's most likely infective endocarditis. And there is something that Dr. Ibrahim Hashim said, is that if a patient presents to you with fever, he has infective endocarditis until proven wrong. This is the video regarding the major complaints and associated symptoms. إن شاء الله راح أسوي واحد بالنسبة للمانجمنت، وإذا عندكم أي سؤال احنا حاضرين.